For the tiniest, most fragile, premature babies, there's a treatment that can save their lungs, but it might come at a terrible price. It's a powerful drug that forces doctors into a really impossible choice, a true medical paradox, and we're going to break it all down right now.
So, the enemy we're fighting here has a name: bronchopulmonary dysplasia, or BPD for short. Just think of it as this relentless inflammation that attacks and damages a preemie's underdeveloped lungs. It makes every single breath a constant, painful struggle. It is without a doubt one of the biggest challenges in any neonatal intensive care unit.
And the scale of this problem? It's just staggering. BPD affects about half, 50% of all babies born before 29 weeks. That's 1 out of every 2 of these incredibly tiny infants fighting for every breath they take. Now, with the stakes that high, you can see why finding a treatment has been a top medical priority for decades.
That search eventually led them to corticosteroids. These are really powerful anti-inflammatory drugs. But as one neonatal expert put it so perfectly, the relationship doctors have with these drugs is one of love and hate. They love what the drugs do for the lungs, but they absolutely hate the potential cost. And that really gets us to the core of this whole story. This treatment is a true double-edged sword. It's a constant, high-stakes balancing act between the amazing, life-saving benefits for a baby's lungs and the potentially devastating risks to their developing brain.
Okay, so the very first strategy doctors tried was, well, it was a pretty risky gamble. The idea was to hit the inflammation hard and fast, right in the baby's first week of life, when their lungs are at their absolute most vulnerable. The logic, it seemed pretty sound. If BPD is caused by inflammation, why not just use a super powerful steroid right away to stamp out that inflammation before it can do any permanent damage? The goal was pure prevention, to stop BPD dead in its tracks.
And this is where that terrible choice becomes crystal clear. Doctors had 2 main options. On one hand, you have dexamethasone, which was fantastic at preventing BPD. But, and this is a huge but, studies showed it significantly increased the risk of cerebral palsy. On the other hand, you had hydrocortisone, which was safer for the brain, but it just didn't work as well in the lungs.
And on top of the brain risk, a whole list of other serious side effects started popping up. We're talking about bleeding in the gut, high blood pressure, and problems with growth. Now, a lot of these could be reversed, but for a tiny baby already in critical condition, any one of these complications could be life-threatening.
So ultimately, the medical community reached a very clear verdict. The risk of causing a permanent brain injury, like cerebral palsy, was just too high a price to pay for the benefit to the lungs. That early, aggressive strategy, it was just deemed too dangerous.
But doctors didn't just give up, no way. Instead, they went back to the drawing board and developed a new strategy, a later, much more cautious path that learned from the hard lessons of that early gamble.
The new consensus has 2 really fundamental changes. First, you wait until after the first week of life, when the brain is just a little bit less vulnerable. And second, you don't give it to every baby. You have to be incredibly selective, reserving this treatment only for the infants at the absolute highest risk.
So what does high risk actually mean here? Well, in the clinic, it means a preemie who is still so sick after 7 days that they literally cannot breathe on their own. They are completely dependent on a mechanical ventilator. These are the babies who just aren't getting better.
And this, right here, was a massive shift in thinking. The goal is no longer to prevent BPD from ever happening. The new, much more focused goal is simply liberation. To get that breathing tube out of the baby's throat and get them off the ventilator, because the ventilator itself carries its own set of risks the longer it's used.
And when you look at how the drugs perform for this new goal, the difference is just striking. With the more powerful dexamethasone, you only need to treat 2 high-risk babies to successfully get one of them off the ventilator. But with the safer hydrocortisone, you'd need to treat 9 babies to get that same result. For this specific job, dexamethasone is just way more effective.
So the whole philosophy today is about being a minimalist. You use the absolute lowest dose that can get the job done, and you use it for the shortest possible time. Think of it like a surgical strike, not a carpet bomb. You get in, you get the breathing tube out, and you get out, constantly weighing that risk-reward balance.
Now, this constant calculation of risk, it's stressful and it's imperfect. Which, of course, leads to the question, what's next? And that sparked this ongoing search for a better, safer way to fight BPD, exploring all kinds of new frontiers in treatment.
Which leads to a really logical question, right? If the problem is in the lungs, why are we flooding the baby's entire system with these powerful drugs? Why not just deliver the steroids directly to the lungs, maybe with something like an inhaler?
So let's do a quick recap of where we stand today. Early systemic steroids? Nope, not recommended. The brain risk is just too high. Late systemic steroids. Yes, recommended, but only very cautiously for those high-risk babies. What about those inhaled steroids we just talked about? Well, surprisingly, they are also not recommended. A few big studies found they might actually increase mortality later on, which nobody expected. But there is a very promising idea on the horizon, combining steroids with something called surfactant.
Okay, so surfactant is this stuff that naturally helps our tiny lung sacs stay open, kind of like how soap helps a bubble keep its shape without collapsing. The idea is to mix the steroid directly into the surfactant and deliver this cocktail right into the lungs. Early results look really promising for reducing BPD, but the biggest question mark remains. We have to wait for the long-term data to know if it's truly safe for the brain. So, after going through all this history and all this research, what is the bottom line? For doctors standing by that incubator today, what's the current clinical consensus?
Well, after more than 40 years of study, it's pretty clear there is no simple yes or no answer. The decision to use steroids is an incredibly complex, careful calculation of risk versus reward, and it has to be made for each individual baby in each unique situation.
So best practice today really follows these 4 clear steps. 1. Identify the right patient, a baby who is still on a ventilator after 1 week. 2. Consider a low dose of a systemic steroid. 3. Keep the treatment course as short as you possibly can. And 4. Always remember that very specific goal. Get that breathing tube out.
Which brings us right back to where we started, doesn't it? The entire challenge is captured perfectly in this one sentence. The trick for every doctor and for every family is to balance the benefits you desperately want against the risks you desperately want to avoid.